Good morning. My name's Glenn Sorensen from Age Communications, and I'm your facilitator for this MOD.A seminar today, or MOD.A webinar, that's going to talk about information and answer some questions about the recently released Commonwealth Home Support Program Manual, the National Fees Policy for the Commonwealth Home Support Program, which we're going to call CHISP today, because it's just a little bit easier to say, and also the Good Practice Guide for restorative care approaches. I'd like to introduce our panel today. On my left is Michelle Newman, who's the HAC Transition Manager from Age and Community Services New South Wales and ACT. Next to me, on my left, is Associate Professor Katie Bridge from the Home Modifications Information Clearinghouse at the University of New South Wales.
Hello everyone.
On my right, Anne Reid, who is the Chair of MOD.A and is also the CEO of Scope Access.
Hello.
And Michael Bleasdale, who's the CEO of MOD.A.
Hello.
Today, what we're trying to do today is to seek feedback on this on the CHISP program documents that have recently been released, and as part of that process, we've invited you to today's meeting. I can see that we've got about 32, 33 people online already, so welcome to all of you. And we hope that number will grow over time. Now, today's just the beginning of a conversation, and we're going to be looking at the questions and discussions that emerge from this meeting. Will inform part of MOD.A's submission in response to the CHISP proposals. Now, we've already received questions from Tasmania, South Australia, Queensland, and New South Wales. So thank you very much for sending in questions. And MOD.A has also got a survey which has been sent out to members recently, and we encourage you all to complete this. So if you haven't done, this will also inform our feedback today. We're not aiming to resolve things today. Where we know the answer to the questions, our panel will give them, but there are lots of things to clarify, and we must remember that the documents that have been released are draft documents. They're not final documents as they are. As a result of today, we will have a much better idea of what you need to know and what's important to you. Now, let me talk about how we're going to work today. We've grouped the issues and the questions we've received under 4 headings, and we'll talk to each of them in turn. The first one is about the client pathway, and that's the interface between the new sole entry point at My Aged Care, the regional assessment services, which are about to be set up, and funded home and modification maintenance providers. The second area we'll look at is fees and funding. So we'll look at implications of the proposed national fees policy and the $10,000 cap on home modifications. Thirdly, we'll look at re-ablement and wellness. And finally, we'll look at operational issues, things like software platforms, volume and level of jobs, maybe some rural and remote issues. Now, we encourage you to actively participate in this webinar, and you can do so by putting questions, typing questions into the chat box. There's a chat box on your screen, and we can see those questions as they come in. And so if you type them in, then we'll attempt to slot them into the program, and if we can't, we'll answer them at the end, and if not, we'll take them on notice. So please participate at any time. It's okay to type in a question. Well, we're going to start by I'm going to ask Michael Bleasdale to start off with talking about the new manual and how it might impact on providers and what MOD.A is planning to do in order to engage members and stakeholders in this consultation process.
Thanks, Glenn. So in the next hour or so, we'll be discussing the new Commonwealth Home Support Program, the draft manual that has been released, and how it's going to impact on providers and clients of home modification and maintenance services across Australia. We are broadcasting live, and we will be recording this session, so it will be available to other people later on after we finish today. So these documents, which is the manual, the draft manual of CHISP, together with the National Fees Policy, and the Good Practice Guide for Restorative Care Approaches, were released in early March. And that was just prior to a round of national sector briefing sessions that were being provided by the Department of Social Services across the country. Now, we're roughly halfway through those, We've done New South Wales, Victoria, Tasmania and Northern Territory, and I understand today they're in Western Australia, moving on to South Australia, Queensland, and ending up in ACT on the 10th of April. So if people haven't had the opportunity to go to those briefings, I would encourage you to do so. The CHISP, we know, is going to come into effect in July, on July 1st, 2015, so that's not a long time away. The manual that we are looking at and discussing today obviously puts forward a number of a broad framework for how that's going to operate across a range of different service types. Now, some of this won't come as much of a surprise. There was a discussion paper released in 2014, and there were submissions invited and provided around the middle of 2014. So around that time we were aware that, for example, in home modifications, it was likely that we were going to have some cap or limitation on the amount of Commonwealth contribution, and the figure of 10,000 was mentioned in that. So some of those things haven't come as a great shock to the sector, but in terms of how we implement that, how we operationalize that, these are the sorts of things that we now need to engage in as a sector and feedback to the Department of Social Services. One thing that was in the discussion paper was the separation out of some services into outcome type streams. Now that hasn't been translated into the manual that was coming out, and you'll find that home modifications and home maintenance services are now within the same sub-program within that framework, community and support. Some of the key things that we're focusing on today, and are the things that you would want to look at in the manual, is the operation of the new My Aged Care Gateway, which come into effect on the 1st of July. I think a major point of discussion for us will be the new level of funding that's provided and the caps and limits on the amount of Commonwealth contribution, and also the setting of a consistent fees policy across the program and across states and territories as well. And there will be very much an emphasis on restorative approaches. So these are the sort of things that we're going to be dealing with today, and these are the sorts of things that people are asking questions about. After this webinar, we will be feeding back information directly to the Department of Social Services. They have asked for submissions to be provided to them prior to the 15th of April, and we're going to be putting in a comprehensive submission. Glenn's made mention already of the survey that we put out to members and other people. We do encourage you to view that and to respond if you haven't done so already. And we'll also be taking the information that we gather from this webcast and putting it into our submission. It is important that as a national organisation we provide a broad national view of how this new national program is going to be rolled out and its impact in the various states and territories. So we will be developing a draft shortly. We would hope to get a draft submission ready around about Easter time, and then it will be provided to members for them to feedback. And at this point we're anticipating having another teleconference before, so that we can get member engagement prior to making the submission on the 15th of April. So with that, I'll hand back to you, Glenn.
Thanks, Marshall. Well, let's kick off and start looking at the implications of the new client pathways. As you know, or as you should know, the two new levels have been added. The sole entry point to aged care system through My Aged Care, and the soon-to-be set up regional assessment services. And I'm just wondering if, just to clarify one of the questions that came through, will all CHISP clients who contact My Aged Care be referred to a regional assessment service?
No, my understanding is, and certainly it's implied in the documents, is that the first port of call is definitely the telephone assessment through My Aged Care portal. It's that telephone assessment and some of the triggers and questions that are in that assessment that will define whether a person needs to be moved on to a face-to-face regional assessment team. The regional assessment team will actually then book a face-to-face meeting, and that will be a longer assessment and look at more complex needs. the way the questionnaire is, the national screening tool is set out, I understand there are triggers within that indicate where a person would be considered to have more complex needs, and that's when they'll be referred on to the regional assessment team.
Certainly, I guess at the moment that some services, home modification services and the clearinghouse, are directly receiving referrals from the My Aged Care portal, where people have indicated that they just want home modification services but don't know where to start or where to go.
And my understanding is that that is likely to continue, that from My Aged Care, from the contact centre, there can be direct referral to service providers.
And I guess the other thing that I'd like to say about that, which I guess raises some concerns for me, is that the screening assessment as it's currently constructed treats all homes as equal. So it doesn't ask whether you're you know, in a place that's got snow or a place that's a cyclone area or where there's likely to be termites. It doesn't ask about whether you're in a mobile home or whether you're in a strata title. So all of these, of course, can affect whether home mods are or are not feasible for you.
I'm wondering, one of the questions came, is it anticipated that the regional assessment services will have OTs on tap, you know, as part of it?
I believe some regional assessment teams where they were successful in tendering for the process may have OTs on board with it, but those who don't, I understand if an OT assessment is required, the regional assessment team will have to send that back to the gateway for that job to be put up or sent out to funded providers. On your first question, Glenn, in terms of the one entry point, I think an issue for us to flag within our submission is certainly the difficulty that providers will have in terms of advising clients that they can't help them, they can't do the intake for them, they'll have to send them on to the gateway. And I guess our concern would be that will the gateway have the capacity to actually quickly answer those phone calls if you're passing on a number and saying that they will do the intake for you. How long will it take for the client to be able to actually access that intake service?
Yes, I don't think it is clear. It certainly isn't clear to me from reading the manual that there will be sort of equal access to specialised assessments, as you know, in areas from state to state, and you know, within areas across, you know, within states as well.
Yeah, I agree, and it is one of the things that came up during the review prior to the manual coming out around home mods and maintenance last year. And one of the things that subgroup pushed for through the NACA advisory group was that there must be an OT assessment. The way I read the manual is, in fact, that the OT assessment are done at service provider level, which I think is an issue, and I'd be interested in the feedback because obviously ACS is putting their submission together as well. But I think it's kind of critical that those assessments be done at the RAS level in terms of the independence about options that are available, because home mods may be one option, but likewise, goods and equipment assistive technology may be another option for people. So, and the two, you know, they both could be options that are available to people on an ongoing basis. So I just think that kind of specialist assessment remaining independent through the RAS might be the way to go, but I'd be interested in what feedback is from everyone else.
Well, client-directed care would come into that as well too. If there are various options to solve or find a solution to a client's problem in their home, if you read the tenets on client-directed care, it would come down to those options being provided to the client and the client making a choice which way they wanted to go as well.
I guess the only concern I would have about that is I think that it's a relatively poor understanding generally about the difference between home modifications and assistive technology, and many people view them as completely interchangeable. And the reality, of course, is that home modifications are about changing the building fabric in some way, and that triggers, you know, laws and regulations and different types of scenarios like home warranty insurance, home contents insurance, and that's quite substantially different. And also I think that there's a difference in the evidence base about what works for who over what period of time. And again, there's trade-offs that need to be made around that in terms of what might be okay in a short-term situation versus what really would cause long-term damage to a person or to their home if it was in place over any length of time.
One of the other questions that came up is say that that the My Aged Care did refer a person for an OT assessment, and that OT, during that OT assessment, the OT identified a need for other services. Can they make a referral direct to services, or would they need to refer the client back to My Aged Care?
On page 19 of the manual, there's a client scenario that it begins an 82-year-old woman who lives alone, if people have their manuals in front of them. This clearly indicated to me that there isn't clarity actually in terms of the bounce back of does an OT who's done an assessment and feels that there is home maintenance or home modifications required, do they then send that assessment back to the gateway, and then the gateway puts out a job up on the portal for a home modification or a home maintenance service, or does that, as currently happens now, that OT refer directly to the local service or to whomever the client chooses to send that job to? So I think that's something that needs to be clarified on a national basis, because, and particularly because of where OTs and home mod services are located geographically across the country. It's in some areas it's very sparse, and in other areas, metropolitan areas, it's very dense, the number of services that are provided.
And I think the other problem with that particular case scenario is that one of the factors, I guess, about whether you would be on a package or you would be in the community health service itself is the number of services. And it appears in that case that that particular client could in fact be on enough services to trigger a package.
One of the final questions here in this section is which I think I could probably answer, but I'll leave it to you. Clients wanting home maintenance services, can they go straight to home maintenance services, or they'll need to still go through the My Aged Care?
Now, my understanding is that the client pathway for everybody, irrespective of the service, or but for any service provided under the sub-program, need to go first and foremost as a new client through to the gateway to be registered. It's about being registered within the system.
We've just had some feedback from one of the 47 people online that you're finding it a little bit hard to hear. So we'll speak a little louder, and we'll see what we can do about volume. But let us know, certainly do let us know if you are having trouble hearing this. And it might be a particular person that you're having trouble hearing that needs to speak a little louder. Okay, let's move on to the area of fees and funding. There's a first question which is about under the CHIS program, the basic level of support provided should sit under the lower limit of the home care package, which is currently about $7,500. But the cap for home mods is 10 grand. How does this work, Michelle?
Yeah. Certainly, I think it is one of the things about the fees policy that needs to be clarified, and certainly overall program that needs to be clarified. I know for many package providers at the moment, I mean, I think there's two sides to this issue, and as we move forward, if there is combining of all of the community programs, so package program and Commonwealth Home Support program in the future, I think while that's a good thing, I think we need to ensure that we maintain the bits of the program, the current programs that are already working. Now, there are some issues in the package programs at the moment in terms of the levels of the packages and the lack of capacity now to cross-subsidise in any way. So that means that for individuals that are on packages, there's issues about home modifications as well. So I know that doesn't actually answer the question, but the answer is, as far as the department's concerned at the moment, in terms of the documents that we have, the cap for Commonwealth Home Support Program will be $10,000.
For the subsidy.
That's right. So the subsidised component of any modification would be up to $10,000. And I think that's based on evidence over the data, over a period of time, that the data that the department had, that 99% of mods that were being done were under $10,000 anyway. And the vast majority in their data was under $1,000.
Let's look at clients who might claim financial hardship. Who's going to be responsible for assessing the financial situation in those cases? And what supporting documentation might we look at?
Financial hardship will be assessed by service providers according to the current policy, the fees policy. And again, this fees policy is out for consultation and discussion, so the department are happy to have feedback around that. But again, it's kind of be careful at what you ask for. I think that some providers perhaps are thinking that that should be done by Department of Human Services, as it is for package care clients. There are a whole range of other issues around that at the moment in terms of the delays and the confusion that that's causing. And also, other than in-home mods, for every other aspect of service delivery, the fees are relatively low. So we wouldn't want to create a system that's going to cost more to implement than it is in terms of the fees that are being collected. So that's one aspect of it. It also does mean if the department wants some national consistency, however, around those hardship provisions, that there needs to be a greater level of guidance around what that might look like. So whether it's some guidelines or some pro formas or some principles around hardship, I think those are not yet in the document, and they may be things that we would be asking for.
Let's come back to the cap. A couple of questions have come in about the cap. Does that $10,000 cap or the $10,000 subsidy include the cost of the OT assessment and the project management?
At the moment, again, it's something that needs clarification, but I think it does, because the way the manual reads is that those specialised assessments will be done by service providers. That's why I think it is a better option for that to be done at the RAS level, because for a whole range of reasons. If you go out and do the OT assessment and then the client decides that they actually don't want to go ahead with the modification, for example, that means the service provider is paying for that. Now, the premise of the new way of doing business is that service providers are not doing the assessments. So I think there's a bit of an anomaly in terms of the home mod structure that needs to be clarified.
How will the $10,000 cap per year work? Will it be from the date of application submitted, the financial year, or the calendar year?
Don't know that answer, Glenn. I mean, I'm assuming it's for a funded year, financial
So
year.
it'll be financial year, I would imagine, yeah.
Michelle, I might just ask you to speak up a little.
Okay.
Next question is, what if a client's eligible for assistance, they access the support, and then they decide, for whatever reasons, not to make the required client contribution? Now, will the service be able to decline or withdraw further support until the outstanding debt is cleared?
Yeah, I think there are some guidelines around this in the manual, and it is about the provider doing as much as they possibly can to work with the client to be able to repay what they have agreed to pay, and then working through a process with them before ultimately withdrawing any service to ensure that there are some other supports available for that client. So it is a bit complicated. I don't think that it's clear, but there is capacity for service providers to be able to withdraw service.
Can I just speak to that? With home modifications, which are often a higher one-off cost than ongoing services, traditionally block-funded, particularly here in New South Wales, block-funded services have allowed clients to do what we call term payments, interest-free term payments to pay off, to negotiate that to pay off rather than find the one big lump sum of money with it. Where we are logging that in the future under MDS or whatever data collection point turns up with it, we're saying that, for example, a job might cost $12,000, the client's contribution is $6,000. The subsidy cap would be $6,000, so that would be under the $10,000 with it. But the client has no way, shape or form of coming up with $6,000 immediately with it and asked to pay it off over a significant amount of time in small amounts. However, in terms of cash flow, as long as you're block funded, that's okay because you can keep floating with it then. But I'm wondering how the department will actually look on those client fees and if we've claimed an amount against the funding and we're only claiming the 6,000 but we're saying a job cost 12, they're assuming we've got the 6,000 back from the client there, but it may be a few years before we actually ever get that amount back there with it. I noticed in the new acquittal processes for home mods, you or for all of the services, you won't have to actually include client fees in that. But I don't know. I'm just wondering how the government will look at how we're acquitting processes and make the assumption that we got that money back from client fees.
I actually think this is a quite big issue for older people. We're sitting on some data at the moment. Previously published data has indicated that about 40% of older people who get home modifications live alone if they're on low income, and we know that the majority of people over the age of 75 are, and that they have an annual income of less than $7,000 a year, then we've got a serious problem. So I think that we need to be talking to the government about some way of having some banking organisation help in a sort of a no interest type program around home modifications. I know this has been trialled in Queensland before and had some problems with uptake. But I can't see how we can manage this without services going bankrupt otherwise. And for this particular client group, older people living alone on low income, where their biggest asset is their house, the only other option they have is a reverse mortgage, and that has huge intergenerational equity issues.
Well, for services that only have a small amount of block funding, they wouldn't have the capacity to be able to take on the larger jobs because they would be using up too much of their funding in subsidy and not getting that client component back for some period of time. So in a way it will actually designate supply, the ability to supply to the larger home modifications as well.
I think the other part, I guess, about involving possibly some low interest or no interest loan system of some kind at a national level is that it would encourage people to do modifications that would increase home value and not decrease home value, which would, I think, be important overall in uptake.
Let's come back to the cap issue because there's a couple of questions that have come in about the cap. Just being clear, if it's a $10,000 a year job or it's a $10,000 subsidy. It's the subsidy. Does this mean that given that a job might be over $10,000 and the cap is $10,000 per year per person, could you split a larger job over 2 different years?
I don't know the answer, but I think the intent from government is certainly that wouldn't be happening. But I get, it's going to come back to where the point of assessment is. So it's about assessed need. Therefore, I think over the longer term, we're going to see that the jobs that are going to actually be approved in terms of modifications will be smaller jobs. Because if we look at the other states, and I'm sure there's other people online from other states, the anomaly in New South Wales around the $40,000, the cap previously, means that there's different expectations here, I think, to what there are in other states. So I think over the long term, the level of job will change anyway. I'm not saying that whether that's a good or a bad thing, but I think that's a reality. And certainly that's what the Commonwealth Home Support Program is about. It's a smaller amount of service for a larger number of people.
The reality is the thing I think for service providers is that, and particularly in New South Wales, but I think that every state and territory is going to have its issues in terms of segueing into this type of new system with it. For most states and territories, I believe that's actually a lift in the subsidy cap, and there'll be more modifications at a slightly higher level than what there has been available previously. For New South Wales, it's a significant drop, and the reality I had to come to in reading the manual a few times with it was that I had to go back to the very first page that says this is a basic entry level program. With the most number of clients being able to be provided with a basic level service with it. And I think that's a different mindset certainly for New South Wales providers. And clients actually too, who become used to the idea that that cap's available. Yeah.
Let's go back to, let's talk about the schedule of fees. The service will be required to have an advertised schedule of fees that clients and their families can easily access. Does this mean that a service will need to have a contract with the client defining the type of service provided, and the limits to the frequency of the service and the repayment schedule options? And if there is a need for an agreement, will standard agreements need to be approved by Department of Social Services?
Specifically to home mods, I don't think that there's anything in the manual or the fees policy that I've seen. In terms of the normal process, my understanding is that after a person is assessed through either the gateway or the RAS, they will then have a support plan developed there by the person doing the assessment. And then when they are referred off to a service provider, the local service provider will still develop a care plan or service delivery plan, whatever you want to term it. So I'm assuming that would be the same with the home mods provider. But I know currently that you have different contractual arrangements with individuals, and so that is something that you would need to ask the department.
One of the issues that is clear, I guess, about how much the department is contributing, but if the job itself is bigger, then by law, under building law, a contract could be triggered. Now the problem with that, as that would be a building contract, that cap for what triggers that building contract is different in each state and territory. So I think that is something that people need to be aware of, and that is something which is going to be important.
Yes, and that's something that we will try and capture in our submission, is that it is going to be different. These are sort of jurisdictional variations. I think probably the best way to capture that is by running a number of scenarios in our submission, just to identify, where we think. I mean, we'll always be pushing to see how we can make these, this framework work for us. But at the same time, it's going to throw up some questions around contracts and around the kind of insurances and other arrangements they have to have in place to make these larger scale. Because at the heart of it, even though we're talking here about how the cap, especially in New South Wales, might prove to be a disincentive, certainly in comparison with the past. Certainly the program itself is still aiming to get more and more people to remain at home and to receive more and more services at home. So it's still going to be a very important program. And I guess, what can't be really addressed within the manual itself at the moment is the other sort of things that organisations like ours need to continue to do to encourage people to contribute to these sorts of things if they can, to the extent that they can.
Just before we move on, and it's a question about the costs of getting allied health services clinical reports to support the development of the appropriate scope of work for home modifications. If this is a service, will the client be responsible for a portion of those costs? And if they then decline that work, are they still responsible for that portion of the OT or specialist assessment costs? Sure.
Yeah, again, I don't think that that's clear, and I think it is one of the issues about having that level of assessment at the service provider level, because someone has to pay for that OT assessment, whether they're on staff or they're not on staff, someone's going to pay for it. And really, throughout the manual, it's quite clear that service providers are not paid for assessment, that it's done now through the RAS. So I think it is something that needs to be clarified.
Look, just one more question that's come in about clarification, final clarification about the cap, and it's is the $10,000 cap or the total of all services or just home mods?
It's the home modification. modification.
Okay.
In my understanding of the manual and the fees policy, it's about home modification.
But it will, I mean, the fees policy is about providing a total amount for a client across all of the services that are covered under CHESP.
Yeah.
So if you had the maximum 10K, that would mean that you wouldn't have access to others.
Yeah,
as we read it, is that right?
I don't know that it's as simple as that, and so it probably does need some clarification because, again, my reading is that there's not an intention to put a cap overall on the level of, like, the dollars or the level of service. Okay. I mean, there's certainly, they want to minimise that disincentive between packages and Commonwealth support program, but there's not a capping. And what they say throughout the documentation is that really that's about, if it's about identifying if the needs of the client are increasing, then they should be referred to the most appropriate program, which will be to the package, rather than this is the cap and that's where we cut it off. And or if it's an issue of payment, then you use the hardship provisions.
Yeah, one last question that's come in, because it's an interesting one that hasn't come up, and it's about what are the GST implications of the fees policy?
Next.
Next question. We'll take that one on notice. We'll take that one on notice, but a very good question.
Yeah.
It is.
Okay, let's now turn to the area of re-ablement and wellness and restorative approaches, which are underlying the CHESP program, in fact underlying all aged care at the moment. We're going to turn to Catherine and ask her to just give us a little bit of introduction to wellness and re-ablement and how it applies to the home modifications sector.
Yeah, I think in terms of home modifications, there's a dual role. There's a societal role, which is primarily about increasing the proportion of housing which is enabling for people and reducing the collective care burden. Because one of the things we have to remember about population ageing is that we've got less young people to support the older people as well, and they're going to be paying higher taxes for longer. And then there's the whole issue at a societal level of offsetting the institutional care costs. So obviously when somebody has to move from their own home into a residential aged care setting, then you're paying not just for the care, you're paying obviously for the residential component as well. At an individual level, re-ablement is primarily about increasing utility and health-related quality of life for that individual and their carers. So, and I think it's really important to think about carers not just as, you know, friends and neighbours, but also the home as a workplace. So, and obviously, again, I guess that goes back to the societal issue. And if somebody damages their back, for instance, because there aren't appropriate modifications, they're having to deal with, you know, changes of level, they're having to help people get out of bed, and there isn't you know, appropriate systems in place, then that is, we know there's evidence that that triggers institutional care and hospital costs as well. So in terms of the individual, we're looking at the evidence base where there's significant evidence that home modification can make a big difference to improve safety and confidence, particularly around falls. There's a growing body of evidence around things like improved mobility and autonomy, control, independence. And also, surprisingly, even when you're only looking at the home, a surprising body of evidence around increasing community participation. So if you make things easier for people in the home, they have more energy and more willingness to go outside to the home. And also, we've been working on the substitution aspect, and what we've been able to show is that there's a direct transition, if you like, between paid care, you know, having someone come in and shower and bathe you every day, and having a home modification like a bathroom modification. And in fact, that more expensive one-off cost of having a shower modification in fact becomes cost neutral quite quickly. But the problem, of course, is when you're on a limited income, finding a large lump of cash is often quite difficult. So we've been able to show with some of the work that we've done recently, where we've looked at pre and post home modifications, looking at 154 cases, that we've been able to reduce informal care hours by nearly 50% and the actual formal paid time by nearly 20%. Now, these are incredibly significant. So, and I guess that sort of research hasn't been done before. So, you know, we are obviously talking to DSS about that.
One of the areas that I'm doing increasing amount of work in, and I know, Catherine, it's dear to your heart, is the evidence base. And increasingly services are going to be having to need to demonstrate that they're actually making a significant difference to people's lives. How can support providers individually and collectively as a sector build this evidence base to show that we're actually making that a difference in terms of wellness and re-ablement?
I think there's a number of things that we need to be doing, and I think where we have the clearinghouse specialises in looking at what works for who when. So, you know, when should you put a ramp in versus a lift versus a landscape modification? So that's one level of evidence, and so that's about producing new knowledge and then making sure that there's sector uptake. Now, we know that sometimes that takes time, and when we look at medicine, we know that it's at least 10 years between when they produce that evidence before it actually translates to practice. So I think we can speed up some of that translation to practice by having more conversations and by making sure that when we do education, that the education isn't based on what we currently do, but on what best practice actually is. I think the other part of that is that we actually need to get a lot smarter about sharing data. So, you know, the people at the end who are providing the services, like for instance, if we hadn't been able to work directly with Scope Access and with other home modification providers in New South Wales, we wouldn't have had access to that, all of the data that we were able to get to look at that before and after. Because that's, you know, we had enormous access to amazing levels of data.
What we found interesting about participating in providing some of that data was that clients themselves hadn't, it was an interesting question to clients because historically we haven't asked clients, how did this make life better for you with it? And with the DSS wanting to capture more outcomes ongoing, I think this type of questioning will be part of both your own initial in-touch assessment, irrespective of what's been done through either the RAS or the telephone conversation. It'll be about what the client is hoping for you to help them achieve in their goal with it. We'll need to know that information because I suspect at some time the DSS will be going back and trying to find whether we provided that solution or a portion of that solution with it. So even the way the questions and the scripts we use to do our own home mods assessment need to change, I think.
Yeah, and we have done another project in the New England area with occupational therapists specifically around home modification follow-up, and we know that that's quite patchy. And again, how can people learn when they don't know what worked for who when? So I think we get to get a lot smarter about how we do that. And of course, that's the problem when that follow-up isn't funded or isn't prioritised.
I think this is an important part of the next stage in this development. As we've said all along, we have a framework now through the manual, but there's a lot more detail that needs to be filled in for us to be able to determine how to deliver services, how to handle the fees and all those sorts of things, how to interact with the gateway. But I think the quality indicators and the data that we need to be generating routinely and doing that in a way that's manageable and doing that in a way that's consistent across the country, I think this is the real opportunity to actually put that detail into our submission and say this is what's required in order for us to be able to begin to measure in ways that we frustratingly haven't really been able to do very well over the past 20 to 30 years, be able to measure what we've done and what impact it's had on other people. I think that's the challenge.
And I think the other thing that we find very valuable in terms of things like the clearinghouse, and which has been fantastic for OTs, we have 3 listservs. The OT listserv is one that was originally started by Desley de Jong in Queensland, and it's very much a circular frame, so it's not public, but OTs who are registered can see what other OTs are saying. For the clearinghouse, it's been fabulous in that we understand what people are struggling with. So it helps us identify the gaps and weaknesses, and our advisory committee then can review that information as part of their prioritisation of the next set of work. So one of the things that I would really, really encourage home modification service providers to do, the construction and building sector, is to share that knowledge as well in the same way, because that way we get both the OT's issues, but we also get the construction issues, and we need both sets of data, as well as we need the consumer issues. We also have a consumer forum, so they're free to join. If there's nothing else you do, please go to the website and register yourself and participate. That would be fantastic. That would be a great step forward.
Okay, I want to move on to a range of operational issues to finish up. We've got about 10 minutes to go. And I'll turn to Michael. Will funds be available to assist services to upgrade their IT?
Well, this is a question that's been asked of us, and I, of course, don't have the answer to that, but I think it sort of sits among a sort of a range of issues. Obviously, we've covered off on quite a lot of those issues already in this meeting by talking about those things that do occupy the minds of providers, which is around the fees. It's around setting a cost price of what you deliver. And until we're absolutely clear as to whether or not the assessment takes place within the service provision or whether it takes place within the RAS, we're not going to be able to give definitive responses to our members about how they set those sort of fees. But these are the sorts of things. So it's a range of clarifications that's needed around how the manual, how the CHISP is actually going to be implemented. And as I said, this next phase is about trying to fill in some of that detail. But I think the other thing that service providers are wrestling with at the moment is what the continuation of their funding and the contractual relationship they have with the department actually means. It's getting very close. I mean, let's just announce it again. The My Aged Care Gateway comes into effect on the 1st of July. So that will be a very different way that service providers have to relate to clients. It will be still some questions that we've alluded to here about bouncing backwards and forwards possibly within that. So there's quite a lot that needs to be sorted out, teased out, so that on the 1st of July, services know where they're going to get their clients from and how they're going to get the necessary assessments in order for them to be able to service them. And I think this is really going to, I mean, again, through the scenarios that we put up, it's slightly different in different parts of different states, across different jurisdictions, but by and large, there is a process when you have a home modification, you sort of have an eligibility assessment, and then you're referred to whatever it is you have in your state, and you build up a much more detailed need of what that individual needs in the context of the environment in which they live. And at that point, and we haven't talked much about consumer-directed care, but I think this is where it comes into play. At that point, you would go back, you currently do, and you would do this even more so in the future and say to the client, is this something that you want? Is this something you're prepared to pay for? Because until you get to that point, you don't really know how much it's all going to cost. And so there's elements there of operations about how do you provide that service if indeed that's part of what you're supposed to do as a home modification provider, and how do you report against that if in fact the outcome of that is the person chooses not to do. So those are the sorts of things that are concerning. As we've talked about, it's about setting the price, it's about coming to grips with those fees policies, making sure that you are charging fairly for people, you're not denying people a service on the grounds that they have financial hardship. But I think there's also some more rather fundamental questions about, and this came up, I believe, in the Roadshow, about whether or not the new gateway and the kind of information that's going to be shared backwards and forward on that gateway is going to be compatible with the kinds of systems and IT networks that existing providers have. And can we have some greater idea of what upgrades, if necessary, are going to be in place? And if there are going to be significant upgrades required to be able to speak to and relate to that gateway, that's where that question you just asked me, Glenn, comes in. You know, is there going to be funds available? Because a lot of service providers have invested quite a significant amount of money already in those kinds of systems.
My understanding, I guess, is that services will still need to collect, at least in the short term, the minimum data set. There's been no change in that, so they'll need to have software that's still compatible with that. How they will get their electronic referral is unclear, and I believe that there are discussions with Telstra, Better Health Connect and HSNet, and I know that MOD.A and the Clearinghouse are trying to set up some discussions around that, but I think it's still unclear what that means.
I'm sorry, Anne.
From a service provider point of view, letters came out from DSS, and I'm assuming nationally. The letter that talked about our funding ongoing for some period of time, but under negotiation between May and November of this year. I recall in that letter there was a paragraph along the lines of discussions we'd also be having in terms of resources and support for that transitioning. And any service provider in the ground immediately determines that as more dollars to help us accomplish this. But I haven't seen anything further on that, and I haven't seen anything defined as any dollars that will come into the transitioning. A couple of years ago now, or almost 2 years ago now, some transition money was put out when the funding splits happened between states and territories and the Commonwealth for aged care. But at that point, there was no idea about what type of software or what type of technology would be required for people to work with the portal. So people had to equip that, spend that and equip that with it. So I'm wondering whether the DSS feels like they have given us that money for transition for what we needed to do, but now where there's more definite information about how our systems need to interact with the portal, whether there'll be any further ongoing support or not. I suspect not. The other thing is a lot of our current resources are going to have to go into restructuring our staffing, restructuring the job descriptions of our staff and how they take in information. When you look at some of these scenarios, if the basic tenet is to reduce assessment and reduce asking people the same question again with it. So one would assume you get that MDS information from the portal when it comes through, because that's all basic information. It shouldn't be part of a client record with it. It's about that double dipping or sometimes triple dipping in terms of data entry for that and how that can be reduced. But it's also about the fact that in regions, and I understand, and perhaps people might clarify for me, I understand that a job will go up in a region because they're looking at the aged care regions that are looking around. Yeah. Where there are several service providers actually funded in that region to provide that service, a client that's in your LGA may not necessarily be sent to you as a provider because the aged care portal or the RAS team will read out the list of people who are registered to provide services in that region, and the client will choose on that. Now that could have very different effects on people's levels of funding and how it's impacted, and there isn't any information about how service providers would get that kind of submission back to DSS to let them know the impacts that they're receiving.
We've got 4 quick questions to finish in the last couple of minutes. First one is that following on from what Anne said, is there a possibility that the drive to increase people going into home care packages will decrease the number of referrals to home modifications in CHIPS.
Oh, I do have an opinion on that.
A quick opinion.
A quick opinion, yes. But look, for the last 30 years, historically, there's been issues between home modification services and packages, to the point where people didn't want to spend their package on home modifications. And would sometimes, I'm not saying always, but sometimes, they would put home modifications in under the old hack program and then move the client forward into packages. Now, with the rate of people that will be coming through and will possibly need a package, but until that time will be serviced in the interim with the CHIS program, I see that the same thing's going to happen, that there's going to be a flood of people getting some of the higher costs, unit costs items like home modifications, maintenance and goods and equipment before they go onto their package for ongoing care. There's also the historical problem that service providers who are given packages to administer and also provide ongoing care services, why would they, in terms of being a business and continuing getting funding, why would they recommend a home modification that might minimise the need for ongoing care services? I believe it's very clear in the restorative information and the wellness information that that would be the optimum pathway for a service provider to take. But if we're looking at a more business-like model for the entire sector with it, why would somebody who has a client on ongoing services that they're providing encourage someone to spend some or most of their package on a home modification that will not allow them to continue to have those ongoing services?
Thank you. And look, a final question that will be dear to the hearts of many of you is, do we have any idea when the new service agreements will be ready to scrutinise? Now, the rumour is made. Do we know any better?
Yeah, they are, my understanding is, in terms of the extension, yes, that they should occur around May, but then there will be an additional service agreement, because that will take you up until the 31st of October, and then there will be new funding agreements after that. So that's where the real issues and the real nitty-gritty for particularly home mods service providers will need to occur in terms of negotiation. So moving, and we've made it really clear to the department, as have MOD.A, that that transition for New South Wales around the three-tiered structure is something that really needs to be looked at in terms of the transition. They're well aware of that, but need to have that discussion so that they work out the distribution, what that means in terms of outputs for service providers, etc. So I think it's very complicated.
And I just wanted to address that. I think it would be remiss not to address that. And there are other implementation issues across other states as well, where you've got state intervention, which effectively provides a buffer to client fees. Absolutely. So I think there are some systemic issues, and I think it's really important to put on the table that even though these might be contractual issues with the level 2s and level 3s in New South Wales, we will certainly be getting very involved in negotiating systemically with the department, because it's ultimately, and a question did come up during the conference about how will the money that is meant for statewide distribution, how will that be distributed? And of course, as we sit here now, the mechanism for distributing that will actually cease to be in existence as of the end of June. So we really need to work very quickly to make sure that that money goes where it needs to be and that there's proper ways of distributing it.
Our time together is almost over. I just want to talk about very quickly about what's to come. I want to give you a reminder to complete MOD.A's survey, which is available on SurveyMonkey. And please, as a follow-up to this webinar, you're most welcome to email or speak to us or add any further comments. We've done our best to answer the questions that have come through, and thank you for them. I think we've got most of them. If you go to the email address info@nswhmms.org, and the phone number is 02 9212 0361. You will be able to is that right?
No, it's 02 9281 2680.
My apologies. Yes, you will be able to access this webinar for further replaying, and what will happen, it'll go up on a YouTube channel, and you'll be able to access that through a link through the MOD.A website. Give us a little time, perhaps a week to do that. process from here is to do a draft submission based upon the work today and other work that's being done. The draft submission will be circulated to members, and then there'll be a teleconference, and then the final submission will go into DSS. I'd like to thank our panel today, Michelle, Katie, and Michael, and I'd like to thank you for joining us. We peaked today at 50 people, and we still have 45. That's more than watched the Gallipoli mini-series. Thank you very much. I hope you've enjoyed the last hour.
Thank you.
Thank you.
Well done.